see. Good morning. Welcome to this mini conference session. We have two very exciting topics. This is only two lecture series. This is an hour-long session. We have two 25-minute talks, and we'll have 10 minutes discussion. My name is Igor Belyansky. I'm joined here to my left by Dr. Blake. The first speaker is Dr. Fernando Ferreira from Porto, Portugal, and he will talk about component separation. Where are we 20 years now? Fernando, please. Looking forward to this.
Thank you. Well, thank you very much for this honorable invitation. And once again, the AHS is without a doubt my favorite meeting. And just setting my timer here. And here we go. So I was asked to speak about the evolution of, I'm going to get closer. I can't see too well. I'm getting old. And since we're less people here, can you hear me?
Yeah, just then sit down. Go ahead.
Yeah. Okay. Well, sure, stand up. I think it's easier. Anyway, so these are my disclosures. And it was really tough to decide how I'm going to make this talk. So what I've decided to do is get an overview of things, and once in a while, just get a nuance in there, something subtle to make people realize that you have to pay attention to details to have success in this type of surgery. So without further ado, let's go a little bit back in time. So 20 years, 2004. So we're looking at things that are still the same, rivalry, politically the same. There's a lot of war going on. Facebook actually started back then. It was called the Facebook. And thanks to Facebook, many of us know each other virtually, and now at these meetings we meet. Friends ended at the time, which was a major series. Ronaldo came out, which was a very big problem for us in Portugal, because now all my hernia patients want to have abdomens like Ronaldo, and that's impossible. So obesity also came in. When it comes to component separation techniques, I decided to approach this just like a journalist, why, what, who, when, and where. So looking at statistically, there's a big boom when it comes to component separation techniques since 2004. You just do a simple PubMed search and you'll find it. And what's interesting is that the whole topic of component separation actually started with Albanese from Argentina. But the thing is, it wasn't a real component separation. What he was teaching, and he was an excellent surgeon, was teaching discharge incisions to be able to close incisions. So if you had a surgical incision, as you can see there on the drawing, he was using his techniques to be able to close midline, for example, an incision. So we then add, after that, this is in the 60s, and then in 1967, there's this excellent surgeon from Minas Gerais, also from Brazil, and he came out with the flap technique, the peritoneal flap technique, which again, in the last few years, has been made more popular, and it's been a great get-to technique to amplify the container, the abdominal container, and when you're in trouble, and to decrease intra-abdominal pressure a lot of times when you have a major ventral hernias with loss of domain. Going forward, then we see, of course we all know, the big event when Reeves and Stoppa developed the retromuscular plane and went forward with Stoppa's space, Bogros space, Retzius, and this was basically the foundation for component separation to keep going forward. Ramirez, a plastic surgeon, went forward with this, and to get the midline closure, he started the component separation. So he went through the incisions that were advised by Albanese, and then lifted up the flap. So it was the anterior component separation. And then, of course, the big game changer was the transverse abdominis release. I had the privilege of learning this back in 2013-14 when I met Michael Rosen in Lisbon. And at the time, I was doing interior component separation endoscopically. And it was interesting to see that, you know, you think you have a great technique, but then until the next one comes along. So it's very interesting to see these things. It's a pendulum effect. And what I found was, and I think most of you will see that and have that experience, is that you find a technique which is faster and which you start to adopt more. Anyway, when it comes now down to surgical approaches, you know, you have open, you have laparoscopic, robotic. Well, everywhere, every person has their own way of approaching things. You look at Dr. Nowitzki's algorithm, and it's a massive page because he has all the options in the toolbox. And that's what we need. We need multiple options in our toolbox. So basically, for us at my hospital, this is the way we approach things most of the time. But again, it all depends where you're working. I've spoken to colleagues who, just as me, the insurance companies do not pay fees for minor surgeries, so-called minor surgeries, only for cancer surgeries. So basically, we have to have in there an idea, an algorithm of how to treat these patients. Of course, you'll always have patients if you really love minimally invasive surgery, and I love to do complex abdominal wall, minimally invasive, but there will be patients, as you can see here, where that algorithm does not fit into. So you'll have to go around. When it comes to the technical aspects, and we look at the literature, just as we saw the foundation from René and Stoppa, Reeves and Stoppa, it's basically retrorectus appears to be the best placement of mesh to avoid problems. Of course, we've seen the evolution over the years, and there is still a big debate when it comes to IPOM or for example, preperitoneal. Anyway, so going over the Reeves-Stoppa, so you know, when I did parallel the abdominal wall book from Rosen and from my surgery, just to show that basically when you're doing these things, you have to be very meticulous or else the complications will be high. And that's what's been coming out in the literature. We're starting to see, after thousands of cases all over the world, some complications that are reaching the double digits. So that's very interesting. But on the other hand, patient satisfaction is brutal because we're treating the end stage patients with abdominal wall. So it's very difficult to randomize these patients. And when it comes to component separation, we're using a lot of times this technique, not only for the central hernias, which were done in the past, in the majority, we can now use this technique, the component separation, if we like, for the flank hernias with great success. But mind you, you always need to do a good mesh overlap. That's the key, that's the trick. And that's where a lot of times the TAR, posterior component separation, comes into play, because you can find a pocket and you can go really lateral, and that will be the key to your correction or long-lasting correction of that hernia. So basically, these are different types of hernias. Again, just for historical purposes, at least I still have that in my toolbox, not that I've used it, the anterior component separation. And we looked at the Dutch group where they studied it, and they were able to also show that there is very similar component advancement, but we know that interior component separation compared to posterior component separation, you're going to have some problems when it comes to the epigastrum area. So also when you're doing an anterior component separation, you read a lot of literature about ischemic skin. Well, I think a lot of times we were taught to just go straight forward and lift up the flap. It's really easy, it's cool. But a lot of times we're not taught that we should save at least 1 or 2 perforators. And we have to be careful to save the perforators. Being really fast can sometimes kill those perforators, then you're going to kill the skin. So that's a very important aspect. When it comes to the component separation, the anterior component, video assisted, I think it's very nice. But again, you know, to do the surgery, you have specific situations, and sometimes doing it in a hybrid situation. It was done in the past, in our cases, with open abdomens, where we were actually using this to close the abdomen, minimally invasive. When it comes to, again, to the posterior component, this is something that we all know. It's common knowledge that we're going into a clear pocket which no one has been into, and that's why we have better results when it comes to sometimes contaminated areas, situations. And if we're able to control the contamination in the patient, there are some interesting studies showing that the rectal rectus and that this space, this clean space, will actually have a lower infection rate. So it's very interesting to see, and it's great to see the advancement, as you can see there with the ruler, that we can get with the midline closure. Also, with the big event of Jorge Diaz, Igor Belyansky, and other great people, we've been able to advance with complex abdominal wall surgery, but minimally invasive. So we're pushing the bar. And this is fun in a sense, but on the other hand, it's very painstakingly difficult to start with this type of surgery. So you really have to know your planes. You have to keep the principles of surgery, and you have to know if things don't go well, how to correct things, and then you have to know your planes in case one of your repairs fail. And that's very important when it comes to this. And also, when it comes to robotic, well, basically, I'm not even going to risk speaking here with Igor next to me, so forget that. But keeping on forward, again, like I said, you have different types of planes. So we've seen a lot lately about the retromuscular, but we've also seen some very nice approaches, minimally invasive, with videos coming out from Mexico, from Hector, who's done an incredible job, and Jorge also, as always. And we're doing now some different types of approaches. So when it comes to this type of approaches, and as I said, you have to know your planes so you can place the mesh well. It's fundamental that you know what you're doing, and a lot of times we've seen this, that people join the bandwagon to try to do minimally invasive surgery, and they don't know how to do open surgery. Of course, more and more that is a problem in the general surgery community. People are more into minimally invasive, and they're not able to do openly invasive surgery. But again, Jorge and Dana from Michigan, I presume, they wrote, he has this interesting thing where he said, it's a wild, wild west. Every week there's something coming out in the social media, and these things are being rapidly disseminated on platforms, and sometimes with the wrong approaches and mistakes. So we really have to be careful on how to analyze things and what we're doing. So when it comes to the mesh repair, we've seen the studies, and regardless of the size, there are better results when it comes to mesh repair. So that's the problem when you go on a subway and you arrive from Europe like me, and you see all these things saying, oh, do you have a mesh? Would you like to get money? Whatever. That kind of scares us Europeans when you hear about that. So open component separation with mesh also has better outcomes, as according to this review, multi-centric review from Professor Cockring. And the studies show higher morbidity rate if you don't use a mesh. And that's interesting. Higher morbidity rate. And I was very interested in this, and a lot of times it has to do with suture breakdown, and a lot of times you get incarcerated bowel and post-op. So you really have to be careful with these situations, and you really have to know how to weigh things. So it's important that mesh, in this case, is actually a better turnout. With regards to biologic, biosynthetic, synthetic, there is a problem right now in the world. A lot of people are mixing up the names, biosynthetic with biological, this and that. And I think it's important that we know what we're dealing with, if it's either a biologic, or if it's a long-term absorbable, or if it's a synthetic, okay? And that's very important. And you look at the costs, and we've seen here in this study, sponsored by Dr. Michael Rosen, that after 2 years, in these cases, you could see interesting results just with synthetic, and the biologic results were 200 times more expensive. So it does make you think. Of course, we don't know what will happen with the patients that complicate and how difficult their situation are. But again, both situations, both meshes have shown similar safety profiles. So it's interesting. It has to do a lot, I think, with how you can defend yourself in court if you're deciding to use synthetic or biologic. On the other hand, here, there's a study, the COBRA study, which also was very interesting, showing right there that long-term absorbable mesh showed good results in terms of recurrence and quality. So then again, you have another option here. When it comes to biologics and synthetics, I've said, you have the long-term absorbable, and they're showing good results. But again, these are small series, and we really need greater series. This is a paper we just put out between Portugal and Spain, and we have 236 cases. And if you look at the cases, grade 3, grade 2, they're tough cases. And it was interesting to see that there was no influence in recurrence in surgical site occurrences. But remember, mind you, we're looking only here at a follow-up of 2 years. So you have to be sincere when you're reporting these things. Complications. I just put this slide here. I think this slide is just beautiful. It's from Michael Angelis. If you look at the slide, it's comparing open component separation, ventral hernia repair. And you look on the left and you see laparoscopy. So laparoscopy compared to a ventral show that there's the same overall complication rate, but there's less intraoperative bowel injury and less conversion to open surgery. Okay, so very interesting, but the operative time is higher. So now let's compare the robot to open surgery. And it's interesting to see less overall complications, less surgical site infection, less intraoperative, less, but once again, higher operative time. Learning curve, perhaps, the size of the equipment, I don't know. But again, we need more studies, and it's always redundant what we're saying. With regards to comparatively, I got this study. I think it's from Igor and Richard Liu and some great authors. And it's the initial results back in 2019. And if we look at it, it was actually at the beginning of the learning curve. And it's very interesting to see that when comparing laparoscopy to robotic surgery, you see that the complication rate in robotic is it's much less, 0 cases, compared to the other case of laparoscopy, and less hematoma, less recurrence. It does make you think about things that as soon as you're proficient, as soon as you have good training, you can overpass these things and get good results. Once again, we're back to those extreme cases. But when we look at these extreme cases, once again, we cannot, go on the bandwagon. I can do this laparoscopically, robotically, whatever. We really have to know how to analyze them. And you look there, you have a patient with loss of domain, horrible skin. It's going to go in the bucket in the middle. He has a stoma, has this and that. So you have to use adjuvants. And that's where Botox comes in 4 to 6 weeks before, so that you can have basically a partial paralysis of the muscle, so you can do a better component separation. Pneumoperitoneum, if it is the case where you might have a loss of domain greater than 20–25%. And of course, as you can see here, the decision to put in sub-Q tissue expanders, because we knew that it was going to be tough as soon as we took out that split skin graft in the middle. So you really have to know what you're going to do. Is it dual stage, single stage? And each turn you take can make you basically crash when it comes to these things. Another technique, which is the Madrid technique, is very interesting because if you look at it, in reality, it's defined a lot of times as the TAR variation, the Madrid variation, but it's not a component separation. If we are pure fundamentalists, what we're doing is we're actually going over the fat, the preperitoneal fat, and we're sweeping aside the muscles. So I say, well, then what, who cares? No, this is a very good technique because this has helped us understand better preperitoneal dissection. It's helping us with laparoscopy. It's helping us with robotics. It's helping us navigate the planes. And this is very important. And especially, it's also shown us that the nerves in the more cranial dissection area are more medial and that we can actually cause more harm to the diaphragm. So there's some excellent information put out by Professor Miguel Urania and David Laurier. Saw a video recently. It's very interesting. It's worth seeing how they use this technique to avoid complications of the diaphragm. With regards to the complication rate, as I said, it does reach the double digit. And it's 13, 26%. And you're looking at recurrence rates, which are high. But again, look at the same, you know, basically the big experts, Nowitzki, Henneford, who have actually improved even further their results from 26 to 13%, 7 to 2% recurrence rate. So, you know, there's always room for improvement. And once again, we have to know what we can do and we have to go forward always to get better results. With regards to quality of life, you look at the studies and it's very interesting. Nobody gives a hoot about quality of life, or the majority of surgeons are not doing that. And we know in reality that these patients have better quality of life, but it's difficult to quantify it. But in a picture, in a video, we know that these patients make an abdominal wall surgeon feel gratified, every patient we treat. And looking at this table, you can see here that in the cases where they looked at the quality of life, you can see there's a big improvement. Just for the sake of confiding in you, my first 50 cases of complex abdominal wall surgery, 70% of my patients were on some sort of psychiatric drug, okay? After 6 months, we reviewed those patients. The 70% fell down to 30%. So I could make a conclusion that the best antidepressive is doing a component separation. Again, just for laughter here. Anyway, let's wrap it up. So if you want to have better luck in component separation, be advised. Endoscopic and perforator sparing is essential. You don't want to have necrosis of your skin. Proper posterior component separation is essential, but you have to be very well trained. You have to be careful. A lot of times these patients aren't as nice as we think because they've had drains before and they're going to have linea semilunaris which are rolled up, and we easily destroy these patients. Robot-assisted component separation, well, basically you have to be very well trained to do it. And use mesh reinforcement in all your component separations because the evidence is there, even in the smallest hernias to the gigantic ones. And of course, when it comes to component separation, as it says here, as we saw in the literature, it might be painstakingly long, but if you try for an open component separation anteriorly, you should try comparatively for a laparoscopic one. And again, there's no consensus on the best component separation technique. So after 20 minutes, that's my big final conclusion, no consensus. So I'm sorry. Thank you very much. And you're welcome to come, anyone, or send any of your residents to our European Hernia Society courses. The next one we'll be having is in Geneva. And thank you very much once again.
So we'll leave questions at the end. Thank you so much. That was excellent. So our next speaker will be Dr. Manuel Lopez Cano from Barcelona, speaking about evidence-based medicine for robotics in modern abdominal wall surgery.
Can I do from here? Yeah.
Sure, whatever. You have the floor, sir.
Much easier, yes. So thank you very much. First of all, thank you very much to Archana and Flavio for inviting me to be part of this fantastic meeting. For me, it's a privilege and an honor. The title of my presentation is the EVM for robotics in modern abdominal wall surgery. And the acronym EVM, as you all know, is the evidence-based medicine. Here are my disclosures. I have some financial disclosures, some non-financial disclosures, and also I am a robot user. But I would like here to show you a potential intellectual conflict of interest that I think I have. This potential conflict of intellectual conflict of interest is that I am a baby boomer. And the baby boomer, I am not old, but I am a baby boomer. And the meaning of a baby boomer in my case is that I witnessed amazing changes in the operating room and in the back office during along my career, and also I witnessed the birth of evidence-based medicine during my residency in the 90s, in the last century. So I have some opinions regarding the evidence-based medicine about robotics in modern abdominal wall surgery, but maybe young people here, or maybe a boomer here, can agree or disagree with me, I don't know. But anyway, the first idea I would like to tell you is that the robotic surgery is a surgery with a robotic assisted device. This is obvious, but I would like to underline the word device because it's very important for the understanding of the rest of my presentation, because the robot is a device. So let me say that probably you agree with me that we are living in an age of immediacy. We are living in a world where we are constantly being told to sell ourselves, I mean self-promotion, to be louder, to be more visible. So in my opinion, in this context, the evidence-based medicine for robotics in modern abdominal wall surgery is not just I watch it, I do it, and I show it. I think that the words from Archie Cochran 45 years ago are totally alive and probably more alive than ever. Regarding devices, we need summaries of randomized controlled trials. And I highlight in capitals the words randomized controlled trials because they represent the top of quality information in the pyramid of the evidence-based medicine. Even more, the randomized controlled trials represent the study design with the highest level of evidence in order to demonstrate the efficacy and safety of a new medical device. Remember, the first slide, the robot is a device, a medical device. Bearing in mind these ideas in this first slide in my presentation, let me come back to the title of my presentation. Probably all of you agree with me that the practice of evidence-based medicine for robotics in modern abdominal wall surgery in this case is the best practice we can do. But what is the best practice in modern healthcare? The best practice in modern healthcare, and by extension in robotics in abdominal wall surgery, is the so-called patient-centered care. The patient-centered care is a complex concept, starting with the access to care and finishing with the respect for patient preferences. And the shared decision-making plays a pivotal role in this patient-centered care. But what is the definition of the shared decision-making process? You can find an elegant definition of shared decision-making process in this viewpoint published last year in the JAMA Surgery And you can read here is a process in which patients and surgeons are working together, making decisions about treatments, care plans, and so on, balancing the best evidence with the patient values and preferences. Interestingly, if we look the definition of evidence-based medicine 30 years ago done by David Sackett and colleagues, you can read that the evidence-based medicine is the use of the best evidence in making decisions about the care of individual patients, integrating the clinical expertise with the patient's preferences. So, in my opinion, the definition of shared decision-making and the definition of evidence-based medicine nowadays, they are exactly the same. If you are practicing evidence-based medicine, you are practicing shared decision-making and vice versa, in my opinion. So coming back to the title of my presentation, sorry for this, but I would like to switch the acronym. I prefer to use STM instead EBM for robotics in modern abdominal wall surgery. The shared decision-making process is a well-established process and very well-known process in medicine. The shared decision-making process has three main parts: the so-called choice talk, the option talk, and the decision talk. In my opinion, and regarding the topic today and the talk today, the most important part is the option talk. In the option talk, we should speak with our patient about the patient condition. We need to explain the patient about our own experience, in this case with the robotic platform, and we need to explain the patient the state of the art about the data, about the efficacy and safety, in this case, of the robotic platform. Let me tell you some words of each point. Regarding the patient condition, of course, we need to speak about the patient factors, some of them modifiables, I mean pre-habilitation, for example, obesity or active smoking, and others not modifiables, for example, cardiopulmonary comorbidities. We need to speak about the surgical history with our patient, previous intervention, previous meds, and so on. And in this part of the option talk, I think that it's very important for the surgeon to think about the concept of wrong surgery. The wrong surgery is a wide concept, embracing the wrong patient selection, the wrong site selection, the wrong procedure selection. The incidence is wide. It's oscillating from 0.09 to 4.5 per 10,000 surgical procedures. Obviously, it is not my intention to speak about the wrong surgery in any specific country outside my country, but I can speak about the wrong surgery in my own country, because we have this interesting article published from colleagues from my country, Spain, and they analyze the association of wrong surgery with other type of critical health care factors. It is not my intention, of course, that you read all these forest plot, but I would like to highlight, in my opinion, the three more important risk factors that these authors found. The first one is the lack of shared decision-making, one important risk factor for doing wrong surgery. The second one is the lack of leadership addressing surgical problems for specific patients. This factor can guide us to another type of discussion, I mean, specialized surgeons in abdominal wall surgery or specialized units using the robotic platform. But probably this is a matter of other panel, other congresses. And finally, one factor found my colleagues in Spain was that wrong surgery due to medical devices, not specifically the robotic platform, but I remind you that the robotic platform is a medical device. And I think that we need, as surgeons, to think about that when we are in the option talk, speaking about the patient condition. If we move on to the second part of this option talk, the own experience, when we are speaking with our patient, it's important in the case law. Of course, but it is not the most important in my opinion. I think that we need to have some standardization of the skill metrics handling the robot. And we need to explain the patient that we have some skills, standard skills, certified standard skills, let me say, handling the robot. Some attempts have been done for doing that. For example, in the European Hernia Society with this article published last year in JAWS about the pathway for robotic abdominal wall surgery with a specific robotic platform. This pathway embraces technology training, clinical training, and from the most simple cases to the most complex cases. But however, when we look at the literature and we look for some type of curricula of skills, standard curricula of skills handling the robot, unfortunately, as you can read here, the conclusion of this systematic review very recently published, there is a significant room for improvement in the development of and validation of clinical relevant performance metrics that can be translated to the clinical practice. If we move on to the third part of the shared decision making, the option tool, we need, of course, to speak about the data efficacy and safety of the robotic platform with our patients. However, let me tell you some ideas before entering in the data about the robotic platform in abdominal wall surgery. Nowadays, we know that in the last decades, the amount of manuscripts increased progressively, or published manuscripts increased exponentially, as you can see here in the continuous line. However, the peer review process is capital in the academic process of publication of a manuscript. And we don't have any standard definition about what is a good reviewer. However, we can use some marker to consider a person as a good reviewer. For example, to have the PhD award. This is the dotted line. The red dotted line is the number of PhDs award doctors in OECD countries in the last decades. As you can see, is not in the same direction than the publication of manuscripts. Probably, I don't know, this is one of the reasons that in the decreasing in the publication of disruptive papers. In fact, as you can see here in this second graph, the publication of disruptive papers decreased progressively in the last decades, not only in the life sciences and biomedicine, also in physical, social sciences, and technology. Probably, this is one of the reasons that 60% of what is published will never be cited nowadays. And let me remind here that the words of David Sackett, the father of the evidence-based medicine. We are nowadays, above all, when we are trying to demonstrate the efficacy of a medical device, we are living in a real world data observational studies of efficacy and propensity score era. And I would like to remind you again that the real world studies are no substitute for randomized control trials in establishing efficacy. So this is the reason, because in the IDLD, probably the majority of you knows this rational framework for evaluating and regulating the use of medical devices. In the point 3, in the assessment of the device, we need randomized control trials with hundreds of patients. I look in the literature and I search in PubMed, preparing this talk, about the number of randomized control trials published so far regarding the use the use of the robotic platform in abdominal wall surgery. And I only found 6 with some articles, the same series published after, but only 6. It is not my intention that you read this busy chart, of course, but let me summarize my opinion regarding these randomized control trials. The majority of them, in my opinion, have low level of bias with some exceptions, with some uncertain areas, above all regarding performance bias, with low number of patients included. Remember the IDLD, hundreds of patients, low number of patients included, with, in my opinion, miscellaneous comparisons because the comparisons, there is a lack of comparison with standards of care. I mean open surgery, because the open surgery nowadays, I think that is still the majority of surgeries that every surgeon doing abdominal wall surgery are doing in every hospital. And also, I found a lack of information on key parameters, in my opinion. Readmission rates, outpatient events, long-term follow-up. I mean long-term, more than 5, 7, 8 years of follow-up of these randomized controlled trials. Other aspects as cumulative morbidity or patient-reported outcomes. Probably this lack of integration of clinical trials in the practice of medicine, it's not only because the data coming from these randomized controlled trials are weak. Also, I recommend you or suggest you read this very interesting article published 2 months ago in JAMA, because the conclusion is that we are living in a house divided, as you can read in the title. Because the clinical trials and healthcare delivery companies are supported by separate people, separate policies, institutions, funding, leading at different conclusions, at different incentives and goals. Also, I recommend you to read these other articles, because we are living from the case in a post-marketing analysis of medical devices. And we need to modernize the data infrastructure for clinical research to meet evolving demands of evidence. And we need to share our data among surgeons, among institutions, among companies, among clinicians, and so on. Coming back to IDLD, let me give you some words about the 4-point, the long-term results. And the reason for showing you this IDLD, the 4-point, is because this very controversial article published very recently, where the authors compare or analyze the recurrences after open laparoscopy or robotic surgery, and they conclude that the robot was related with an increased rate of recurrences in ventral hernia repair. I prefer the words, I prefer instead this conclusion, because in my opinion was based on weak data. I prefer to comment you the words that was written by Sadaka and Itani in the invited commentary of this article, because the robotic surgery provides better ergonomics, and probably with experience and proper patient selection, we can improve the use, and we need high-level evidence studies. My final comments, 2 final slides. First, in my opinion, and regarding the title of my presentation, the evidence-based medicine shared decision-making for robotics in modern abdominal wall surgery, in my opinion, is limited. We need efficacy assessment. We need more randomized controlled trial, comparing, in my opinion, standards of care with the robotic platform, and we need long-term results. I mean, 7, 8, 10 years after these randomized controlled trials. We have to define other type of risks, PROMs, PREMs, morbidity, outpatient events. And let me remind you that we have been living in a post-marketing analysis for decades. Probably I am optimistic, or maybe it's a utopia, but I think that clinicians and healthcare companies should have the same objectives in trials. Also, we must continue. I am not against the robot. I start my presentation in my conflict of interest showing you that I am a robot user. We must continue to use the robot in abdominal wall surgery, because we need to do the randomized control trials, and we need to define clinical relevant performance metrics in order to standardize the use of the robotic platform. Because we need all those type of information to practice the concept of shared decision-making with the patient, because it's not only a good practice, in my opinion, it's a legal and moral imperative to practice shared decision-making, above all in the situation, in the context of, for example, medical devices with limited evidence and uncertainty regarding some results or some prognostics regarding the use of these type of devices. And let me finish my presentation as I started. We are living in the age of immediacy. At least in my field, the majority of young surgeons want to achieve success very rapidly, very fast. I understand it. I am not against it, but I am a proud member of the baby boomer generation. So I really like the words of Parks and colleagues in this very, very nice article in Nature last year, where they written that to promote disruptive science and technology, I mean the robotic platform, scholars, I mean surgeons, may be encouraged to read widely and given time to keep up with the rapidly expanding knowledge frontier. Thank you very much for your attention.
Great presentations. Thank you very much, both. I'll open the floor to questions. Anyone? All right, go ahead.
There you go. Hazem Shamsuddin, University of California, Davis. Thanks for your presentations. Regarding randomized controlled studies, we know that this is a high-level method to evaluate those patients. So there's an ethical question here. How do you present this to your patients if you know they would qualify for robotic approaches, for example, and you would still offer them the open TOR, for example? So to my patients, I offer them obviously what's best for them, and if they're candidates for robotic cases, that's what I book them for. So how do you approach that challenging question?
Thank you for the question. A very interesting question, and I think that is the key question: how to apply it when we have limit evidence, the shared decision-making process. Precisely, the shared decision-making process helps us when we have limit evidence. You know perfectly that as surgeon what is your expertise with the robot, what is your expertise doing open access or doing laparoscopic access. We perfectly know, because you have your own databases, what are the complications you have, the level of infection with each type of surgery, the level of complication, morbidities, and so on, and the type of patients you are operating on, because you are controlling all your work. And you, from a moral and legal point of view, as commented in my last slide, you should explain all of it to the patient. And finally, probably the patient will decide which type of approach he wants or not. In my practice, some patients directly ask me that they want that I operate on an inguinal hernia with the robot. Yeah, and they don't want open surgery, they don't want laparoscopy, and they don't only want an operation with the robotic platform, because the access of information of the patient is very heterogeneous. They are coming in my field to my facilities after, I suppose that in your case it's exactly the same, after looking internet, after speaking about it with other patients operate on with the robotic platform, and so on and so on. And
yeah, I believe like in bigger places where they do, a lot of cases open and robotic, it would perhaps be more challenging to, do the randomized control studies, especially if you know that they will benefit more with the robotic approach. That's in my case. But one quick question. How often do you get plastic surgery involved? Like, for example, if you don't want to do abdominoplasty or like umbilical reconstruction in your open cases? Thank you.
In my open cases, we are done ourselves the abdominoplasty, the dermolipectomy. If the access to the plastic problem, let me say, is more complicated, of course, I ask for my plastic surgeon, but in a very low percentage.
I'd like to jump in there for a little bit. I'm Kayla Blake. I trained at Cleveland Clinic. Now I'm in Tennessee, and Cleveland Clinic right now has a randomized control trial going on, open versus robotic ab wall reconstruction. We're about halfway through enrolling, and now I'm another institution that's starting on this. So I am, when I see a patient that is eligible for a robotic retromuscular technique, either Reeve, Stopa, or TAR, those people are the ones that are eligible for robotic or open. So I am having these discussions on, are you willing to be in this trial? So you won't know if you got it robotic or open, but I'm telling them, you'll get the same operation. I'm putting the mesh in the same place. I'll still give you the same technique, but when you wake up, you don't know if you're gonna have a big midline laparotomy or small little incisions. And so that trial's going on right now, to be determined, but it is tough to enroll patients. They wanna know. But some people have already had laparotomies, have a big scar, and they're like, I don't care if you do another one or not. So it is definitely patient dependent.
Yeah, it's also, it's a question if what you compare to what, you know. You're talking about comparing robotic to open. I mean, anyone who does a lot of MIS surgery, I can tell you in advance is going to show decreased wound complication rate in open versus robotic. I mean, it's just what's probably, but when you can start comparing laparoscopic to robotic, you know, like, then you have to ask yourself a question, what is the true benefit of the study and how many people out there are going to be doing laparoscopic transverse abdominis muscle releases? There are some, you know, but a lot of us who were doing it initially, you know, we switched, I can tell you, based on our just retrospective reviews of what we've done in our experience looking at laparoscopy robotics. There is certain BMI where laparoscopy is very difficult to reproduce, and it's just a labor of love. And then the question is, what are you trying to show? Are people really out there? It's kind of like back in the day, 20 years ago, comparing robotic prostatectomies to laparoscopic prostatectomies. Is it possible? Yes, but how reproducible is laparoscopy? So, you know, like, this is a very interesting question, but even more interesting would be to see laparoscopic eye pumps to robotic eye pumps, like laparoscopic inguinals to robotic inguinals. And that's kind of question is, you know, should robot, you know, this is an age-old question. For 10 years we've been saying, is it more for complex procedures or is it organically going to take over our practices? And I think that's what we're seeing at the same time. And the data is just lagging behind. But yeah. Go ahead, Agustin.
Hi. Congratulations for the presentation for both. I'm Agustin Alvarez from Santiago de Chile. I'm a baby boomer too. Okay. My question is a little bit tricky for Fernando. We were listening in the last 18 years that it's not a good practice to use anterior component separation and posterior component separation at the same time. But there's some evidence with a low universe of patients in the last 2 years, Spain group and Jorge Daes, that sometimes when your anterior layer is not close, you can't close the anterior layer, you can add, after a TAR, you can add an anterior component separation in one side, okay, to gain 4 or 5 centimeters. This is my first question. Do you have some experience about it? And my second question, maybe for both, if you need in the same patient to do a component separation and at the same time to do a paniculectomy, which one do you choose, anterior or posterior? Okay.
Next questions, Dr. Alvarez. To make a decision of doing both an anterior and posterior component separation, you have to be in a very, very tough situation, a very tight situation. And these are for the extremes. The Madrid group has mentioned that they did this in specific situations. They are very specific and to say not to use it. I have done it twice, And actually, the one where I had to do it was the case I showed. So I did everything I could adjuvantly for the patient. I tried to save the skin flaps. I did everything, and it was an extreme. But again, what does this do for science? Not much. It does for the patient, in a sense. So I think that, as we're discussing today, only if there's a trial do you want to do something structured and go to that immediately without thinking. But what I mean is, without being in an emergency situation, a tough decision, you know, that's the only indication, I think, when it's in a very extreme case and it's a limited case, and you know that it's something where you hope to get more an advantage over a disadvantage. Of course, you try to counteract that with a double mesh layer, sandwich repair, okay? That's the way I did it, and the Madrid group does the same. There was also another question,
Yeah,
which I got.
the other one was if you have to add
yes.
paniculectomy in
Yeah.
component separation, which one do you choose, the anterior or posterior component separation?
Well, I prefer the posterior, and then I do the paniculectomy anteriorly. For me, because I want to avoid the spaces being together.
And your experience, Igor, too?
Yeah, sure. Can I just say, so that, to also kind of add to the first question? I mean, you're asking an important question, and I think the safe answer for everyone here is that should be avoided. I'm very familiar with Dr. Desa's publication. I think Arapoli contributed to that. So here's the thing. You have to understand what's happening to anatomy when you divide the external oblique muscle and you perform transverse abdominis muscle. You only have the anterior lamellar internal oblique and neurovascular fibers contributing to the anterior rectus sheath. And those thin fibers are now holding the abdominal wall. You're certainly going to get more advancement, but it's important. If you do this, I've done it, but you know, this is not something that would ever promote from the stage, and it should be an extremely rare event, and there's steps that I think you should do before getting out to assure that you don't have a blowout bulges on the side a few months later. I think it's very important to get the retromuscular mesh and get it past mid-axillary lines. And also, what you said, you talked about, Fernando saying the sandwich technique. What we do is, if we ever, again, in rare cases, the external oblique defect between the cut edge and the linea simularis, we will suture in a permanent mesh at the same time. So you kind of restore the continuity of the external obliques with mesh, and then you reinforce everything in retromuscular space. And you have to understand that you really need to be technically savvy and really know that you stay in correct planes, because if you didn't, you're going to create a huge hole in linea simularis. So this should really best to be avoided. Nothing wrong with doing a TAR and leaving a little bit bridge defect. Use a heavyweight mesh. That is very reasonable, and you can use a sac to cover the mesh. And really kind of, you know, the cases that I've done it on is kind of where we close very tightly. We did TAR and close tightly, and the peak aero pressure is like delta changes 8, 9, and we're like, that's very worrisome. So at that point, you can either leave it open or you can do external oblique releases. As far as, next question is as far as paniculectomy and external oblique releases. Typically, again, my go-to is doing retromuscular repair with STAR reef stopus and paniculectomy at the end. I try again not to elevate, not to compromise too much of the perforators. And in my hands, when I do external oblique releases, I am more aggressive, elevating and compromising the perforators. There's certainly, many people know, the perforator sparing techniques, just something that I don't do much. And again, it's a rare event for me to do external oblique releases now that TAR is in my toolbox. Not to say I never do it, but just rare.
I'd just like to add something there. You just need 1 or 2 perforators to save the skin. And now I have another option in my hospital, which I didn't mention because I think you don't have it in Chile, which is fascial tens hernia. So if...
Not in Chile, not in the US
Okay.
yet.
Okay, so it's an option. We have that in standby. And if I have problems with my anterior fascia, I say, get me the fascial tens hernia, and I can use it.
Guys, I'm going to close this meeting, unfortunately. I just realized we're 1 minute over time. Thank you very much, everyone, for the attention.